It was interesting a couple of years ago when we first met, you were talking about how frustrating it was that Australia always seems to be the last place that gets all the new innovation. But I was really excited to see a paper that was put out by a couple of your colleagues talking about the drug-eluting reabsorbable scaffold. I believe that you're talking about the one from Abbott, the Aspiri, versus angioplasty for infrapopliteal arterial disease. And that blew my mind. I thought, oh my gosh, they're on the cutting edge of something right now.
Yeah, so my colleague actually in practice here in the rooms, Ramon Varka, that's his baby. And we actually did the first the original what was it called? The original BVS, the bioresorbable vascular scaffold. The name escapes me, but the first version that came out from Abbott, we actually did a trial here at Prince of Wales where the three of us surgeons were enrolling patients. And it was amazing. In BTK, I mean, we've still got patients who are coming back, and you do a run and you can see that the little two markers where the BVS was, and it's patent and it's healed and it looks beautiful. That really spurred Abbott to invest in that big RCT that you've probably all heard about recently. And the results are fantastic, and they truly are in terms of patency. You implant one of these things, and when you go back and have a look, it looks like it's healed. It looks like a normal vessel. It's crazy how it works. Yeah.
And do you think that will help be a catalyst for driving more doctors across Australia to possibly do more to treat below the knee? Because so many were concerned. I mean, just even here, even in England, because of that revolving door of treatments we always talk about. And this supposedly could at least delay that revolving door.
I hope so, Kim. I really do. I think, I mean, I'll be honest with you. My personal take on the revolving door is it's not such a bad thing. You know, we have this thing over here where you become a victim of your own success, right? Like the reason that patient's coming back to you is because they've still got their leg. Their P.A.D. hasn't vanished. It's not like they're suddenly cured of P.A.D. They've still got P.A.D. and they've still got a leg. So of course they're going to come back to you, right? That's a good thing. And the only thing that we caution is the frequency by which they come back to you. So if they're coming back, you know, every 3 months, that's not reasonable. But if, you know, I have patients who are coming back for procedures every 9 months to a year, but they're enjoying their life. You know, they've got their leg. They're working on their P.A.D. You know, they're not smoking. They're trying to do the walking every day. They're doing all the right things, but their P.A.D. hasn't vanished. And so, of course, things are going to re-stenose, and that doesn't mean that we give up and just throw in the towel and chop off their leg. It means that we do a very minor, you know, sort of day-stay procedure to open up the arteries and let them back and enjoy their life. So I don't think recurrent procedures is necessarily a bad thing.